Patient Case Study. Hi, my name is Brendan Beer, and I'm a nursing student at Concordia University in Ann Arbor, and I'm going to be presenting to you a patient today. My patient is a 45-year-old Caucasian male. He is divorced and unemployed. Prior to his injury, he was a crane operator in Detroit, Michigan, and was a happily married man with one son. Currently resides at the Eisenhower Center in Ann Arbor, Michigan. My patient was a pedestrian involved in a motor vehicle accident on September 10, 1994. He suffered from a traumatic brain injury due to his head colliding with concrete. He was rushed to the hospital where he had immediate brain surgery, which resulted in the removal of 1/4 of his frontal lobe because of the blunt trauma that had been endured. He remained comatose for 4 months. Reasons for admission and present history. From the day he regained consciousness, he had been mostly wheelchair bound. His reason for seeking care was that when he awoke from his coma, he was left with a traumatic brain injury and was alone. His wife and father had moved away without his knowledge, and he had a long road ahead of him. He moved from care facility to care facility before finding a home at Eisenhower Center on May 26, 2011. He is unable to perform most of his activities of daily living without assistance. These include bathing, dressing, eating, and most other ADLs. This is due to his inability to balance and lack of strength in his upper left and lower extremities. My patient's vital signs during my exam were as follows: heart rate 64, blood pressure 100/70, respiratory rate of 12, temperature 98.1, and oxygen 93. The patient experiences lightheadedness due to his hypotension, grading the pain at about 2 to 3. To alleviate the headaches, he takes Tylenol, and it seems to help. Patient attends 3 to 4 physical therapy sessions a week and says it helps him regain strength and confidence. He believes without them he would become completely immobile. The sessions make him tired and sore, but he doesn't mind. The soreness is mostly in his joints, and he treats with ice, heat compress, and Advil. He also mentioned when the pain gets really bad, he will have a pain pill that usually does the trick. Sadly, this is a contributing factor to his medication-induced constipation, but he's also on a few forms of laxatives to handle the situation. Patient experiences frequent nausea due to his moderate malnutrition that is treated pharmacologically. Patient receives all food through a PEG tube. Patient health history. My patient's health history is as follows: cancer at the base of the tongue, which included chemo and radiation treatment from January of 2017 to the end of March 2017. Oropharyngeal dysphagia, hypotension, hypotestosteronemia in males, xerostonomia, nasal polyposis, constipation, malnutrition, ataxia, seasonal allergies, hyperlipidemia, and a history of chronic smoking. Our patient's immunizations are all up to date, and he has no known allergies. From the limited resources provided and the patient's inability to recall specific events, the only confirmed hospitalizations are on the date of his accident, on January 10, 2017, when he was diagnosed with cancer, on March 24th, when he received his last treatment for cancer, and May 5th, when his PEG tube was put in. Our patient is currently taking medication to treat his nausea and vomiting, malnutrition, allergies, constipation, chronic pain, depression, chronic smoking habit, and hypotension. Functional assessment. My patient has been a chronic smoker since childhood. He has reported use of recreational drugs in his younger years and does not drink alcohol. His physical exercise is restricted to physical therapy due to his immobility. He reports that his sleeping patterns are regularly irregular and is used to it by now. My patient has struggled with nutrition ever since his PEG tube placement, but takes multivitamins to try and compensate for lack of nutrition. Psychosocial data. Patient is looked after by an aunt who lives in Arizona who visits monthly. After his accident, he became a very religious man and lives his life the way he thinks God sees fit. His education only got as far as high school diploma, but he's a relatively witty guy. Family history. Patient has a limited family history due to not living with or seeing anyone from his family. All he mentioned was that his father was a smoker and abused alcohol. Review of systems. My patient's perception of his health status is aware. He knows his limits and knows what he is left with. He holds a particularly positive attitude and loves being a bright part in anyone's day. Seems a bit emotionally unstable when talking about his past, but that is to be expected. Neuro exam. Patient is ANO times 3. He had slight confusion when asked questions. He has difficulty with speech and swallowing. He experiences headaches regularly and rated the pain 4 out of 10. He also reported tingling in hands and feet, but no tremors. According to him, his tingling worsens at night. He has decreased coordination and balance. He described his memory as foggy and can be tough to recall. He did not report any history of seizures, fainting, or loss of consciousness besides the coma. Upon my physical examination, I determined he was unable to perform the Romberg test due to him being in a wheelchair. His gross and fine motor functions were impaired severely, but mostly focused on the left upper extremity and lower extremities as a whole. He's able to control all areas of his body, but can't always do exactly what he wants to do. Patient performed mini mental exam and scored a 23 out of 30 on it. He had trouble focusing and doing mathematical tasks. His light and painful touch sensation were obscured. He seemed to be guessing more than focusing and actually knowing. His vibratory sensation is normal, and he responded appropriately. Stereogenesis, graphesthesia, and proprioception were all normal. He was able to recognize all objects, drawing, directional influence on his hand. Second review of systems. Musculoskeletal. Patient is a 6-foot, 160-pound male. He reports oropharyngeal dysphagia, ataxia, malnutrition, and hypotestosteronemia. He has pain in his left upper extremity due to arthritis. He rates his pain at 5 out of 10. He also reported aches in his lower extremities due to immobility. The pain was described as stiff and tight and rated at a 6 out of 10. Pain is induced by exercise. The only exercise he experiences is physical therapy and moving around in his wheelchair. Physical exam of the musculoskeletal. Patient has a slumped over posture with slight kyphosis and has unsteady gait. He has reduced range of motion in his neck, shoulder, elbow, fingers, and wrist. I found crepitus, joint tenderness, warmth, and slight swelling in every joint of his left upper extremity. He has assisted full range of motion in the lower extremities and crepitus and joint tenderness in his knees and ankles. Muscle strength in his right arm is rated at a 4 and a 1 in his left. His lower extremity strength depends on if he had therapy or not that day. Without it, it is at around a 1, and with it, around a 2. Pertinent systems. While assessing my patient, I concluded that 2 pertinent systems would be appropriate to assess. These systems include peripheral vascular and skin. With our patient being mostly wheelchair bound, he is mostly immobile and unable to move his muscles. When this is the case, I am automatically worried about the patient's circulatory system and skin integrity. Pertinent system number 1, peripheral vascular. With my patient's poor musculoskeletal status, immobility is a major concern for me. According to HC Pro's Nursing Library, published 2012, immobility can increase edema, pooling of blood, increased pressure in legs, and reduce circulation. All of these are risk factors of an embolism or stroke. And with my patient's history of brain trauma, a stroke would be the last thing he needs. Pertinent system number 2, skin. Patients who are mobile are 91% more likely to develop pressure ulcers. This is according to the Indian Journal of Plastic Surgery, who published an article on pressure ulcers and their causes in May of 2012. Pressure ulcers harbor infection and raise mortality rates 22% for stage 3 and 4 in the first 6 years. Due to our patient's musculoskeletal status, immobility is a huge restraint for him. Constant checks of skin and rotation while laying down can help prevent these. Thank you.